Ok. Je peux garder ça? Non, ok. Hi, everybody. I hope you're doing well. Sorry for some slight delay that we had for technical problems. I'm very happy to be able to talk to you today for many reasons. One of the reasons is that there are more than 1,400 registrants for this webinar. And I will look at in live, but this is completely in live. So when I'm speaking at you, I'm there at the same time. I hope there will be questions also that raise your interest by what I'm going to talk today. Now, let's not lose time and go directly to the topic of today. So this slide doesn't go further. Let me see if I can click here on. Okay, that's it. So today I'm going to talk about immunology, about boosting the immune system with hormone therapies, nutritional therapies, and dietary therapies. It's actually the topic of 8 sessions. We will see this in more detail. A video session of 2 hours or slightly more. And actually, this is possibly the best answer we as physicians or as professional health care are able to give to the COVID-19 crisis. It's also the most forgotten topic, actually. Everybody says that some people have a deficient immune system, but they're not talking that we can boost that. And then we can probably repair almost everything on the immune system that we would dream of. So this presentation is an overview of the content of 2 modules. It's a model that we split in 2, and there are 8 key online video sessions of 2 hours each. And they all provide strategies, intervention, therapies that boost your immune system beyond what you would have thought was possible, and very scientific, all evidence-based, and there's some information that is really experience-based, but you will see there's a lot of strong, solid information. So attention, please, to this training program. It's actually the 8 other sessions will follow this overview. And the whole training program of many modules is called evidence-based hormone therapy, despite there is also a lot of information on diet and on nutritional therapies, because you cannot do adequate hormone therapy if you don't master the science of nutritional therapy and diet that boosts really the hormone therapies. And this training program that is mainly for physicians, but people, for pharmacists and other health professionals can ask to have an authorization to attend. There are live webinars and online videos. This is a live webinar, but this is an overview live webinar for 8 sessions. So it will be a little longer. Normally, those free webinars are 40 minutes with question and answer after. And this will be a little longer. It's also a 2-year training program with modules of 1 to 2 months, which can be attended separately. So you can just attend a module, or you can even attend just 1 session if you want. 1 session is on average 1 hour and a half and 2 hours, but I can tell you there's so many information, so many slides that I have often structured a presentation of 650 slides back to 250 slides. So there is, it is generally 2 hours. PowerPoint presentations will be given like now, and question and answer sessions will be provided at least once a month, if not twice a month, when there's a free webinar session. And there will also be CME and CPD credits, their certificate of attendance. These are the European certificate of attendance, but basically they correspond to also CME credits in USA. So it's valid as CME credits for the United States and for many other countries. And there's no additional home office work to do, but basically you will be so fascinated that I think you will adapt the treatments into your practice, because everything's based on the practice. So the first 2 modules are module 1 and 2, and that go from end of October to beginning of December. And there's an advanced, it's all under the cap of advanced immunology and hormone therapies. And excuse me, why are you doing this? Okay, sorry, we have to wait a little moment. One of my technicians says we're not on Facebook on the same time, and he wants to do the necessary for it. So basically, this training program is really, it corresponds to what you need. In our world, we cannot do training programs without a lot of evidence, but you also need to have something easy and practice-oriented, and that will be possible. And the question and answers will permit you also to go a little further with practical questions that are on your mind. So don't hesitate using them. Can I use now my screen back? Okay, thank you. I have my screen back. Probably you saw the screen, but I didn't see. So we have actually a module 1 will be based on how to prevent and treat viral, bacterial, fungal, and parasitic infections such as the COVID-19. Module 2 will be on inflammatory disorders. And I have discovered a lot by doing all the research. I can tell you, I've done 6 months of research on it. So 6 months that I do is usually a year or two that others do, not only because I think I can be efficient, but also because I really worked in the weekends, I worked in the evenings, and I had a lot of people helping me to find all the references and new data. So let's look at Module 1, Hormone, Nutritional, and Dietary Interventions. And there will be one on dietary, environmental, and lifestyle therapy. The next one will be on nutritional supplementations, how to combat infections with nutritional supplementations. And then there will be also thyroid and thymosin alpha-1 supplementation. You remark that I'm talking about supplementations and not therapies. I do talk now and then with use the word therapy, but less and less, because what we're giving here is not a foreign drug to the body. We're just correcting here what the body needs, a molecule that it has, but in insufficient amount when it has an infection, or insufficient amount to have a good immune system. Cortisol and DH supplementation will be the focus of the fourth, and you will be fascinated and never forget how important cortisol is and how safely it can be used when it is used with DHA together. They even have synergetic effects, but also DHA protects from the bad effects of cortisol. And then there will be quite a fascinating seminar on melatonin, which is major molecule. We'll see why. Growth hormone, estrogen, progesterone, testosterone, and vasopressin supplementations for getting a good immune system that can prevent you having infections. And then, so nutritional supplementations will be really the focus of the first and the second of these sessions. In the first, I talk about probiotics, and you will have a glue here also in this presentation of what I'm going to talk about is much different than we use. It's not only the probiotics you need into your intestines. And then the hormone supplementation 3 sessions. The module 2 will be hormone, nutritional, and dietary intervention for inflammation. And the first will be diet and nutritional supplementations, are environmental also, very important also. And then the second will talk about thyroid, adrenal, thymosin alpha-1 supplementations. And the last then will be also about many hormones like melatonin, IGF-1 growth hormone, estrogen, progesterone, and testosterone supplementations. So first will be again a nutritional supplementation session, and the 2 others will be for hormone supplementations. Now, let's look at Module 1. Module 1 will talk about dietary, environmental, and lifestyle therapies. We'll also have something about probiotics and immune-enhancing diet. And so let's go already to give you a clue of what this will give to you. Wearing a face mask. We'll talk even about wearing a face mask, because so many people say, oh, it is not necessary, or it doesn't really protect you, it protects the other one. No, that's not true. And you see, even the Mona Lisa puts the mask on. So why would you avoid putting a mask on when you have a risk of infecting others or getting affected by others for the moment? And one of the studies that was done in Hong Kong showed that that hamsters can be infected by the COVID-19. And so the idea of the researchers was to take cages of infected hamsters and to blow a wind towards other hamsters that had no mask protection. And there were one where on the cages, a mask was pushed to protect them. And what happened is how much transmission of the virus is after 1 week. Now, 2/3 of the hamsters that were not protected were infected, but only 35% of the hamsters that had worn a mask on their cage got infected. So that's 2 times less. So you say, hooray, we have to put a mask on. But what is the most surprising here is not the data that a mask protects. The data is that 1/3 of the hamsters that were not protected after a week were still not infected because they have a better immune system. And so you can also put the mask on the cage of the infected hamsters. And then what you see is that there is 4 times less COVID hamsters that get infected. But still in the same double experience, the hamsters that were not wearing a mask, 1/3 did not get the infection. We'll see probably why. One of the reasons, don't forget, is that their mucosa, the epithelium of the respiratory tract, is larger, bigger, and defends themselves much more. And there are a lot of ways to improve that. So another factor to protect yourselves is that there must be a warm climate and 50% humidity. That has been in experience be shown. We'll look into data. We'll look with what dry air does on respiratory epithelium. And here you have an idea. For example, the graphic on the left shows you a thin respiratory epithelium from the trachea and from uninfected mice. So it is thinner than the epithelium when it's when the mice are in an atmosphere of 50% relative humidity. They're thicker airways and thicker airway epithelial cells. So when you look at below, what you see is that the infected mice there because they had they were in dry air, there was 10% relative humidity, it's very dry air. They had actually a sort of impairment of the tissue repair. It was not a nice respiratory epithelium. While when you look on the left, mice that were infected, they had, with thicker airways, actually, they had an even thicker airway. So there was a sort of proliferative response of long epithelial cells. Just the only factor is different is there was enough humidity in the air. So the first thing that we did when there was the COVID is that we put air humidifiers all over. And to my knowledge, up to now, none of the persons, while we still kept working, we still kept seeing patients, nobody got infected here, thanks to the air humidifiers, because the air was humid enough and we had better respiratory epithelia. Here's another graph that shows you the viability of coronaviruses at different room temperature, room humidities. And you see that the 20% relative humidity, very dry air, well, basically, the coronavirus keep on living and keep on. Still, 80% were on a visible surface for a week, after a week of being there. At 80% relative humidity, so more humid, but very humid, well, there was still a certain percentage in between, like 40% that were of coronavirus that were still remaining. But when you look here, after 2 days, with the 50% relative humidity, there was 200 times lower levels compared to 20% relative humidity coronaviruses that were still viable, still living. So less than 1% after 2 days. So there's much less infection risk. So you need to put the air ambient at 50% humidity. So how to detect excessive air dryness? I'll give you a trick, because the whole information is that you directly can discern and know what is going on in a patient. If the air is sufficiently humid, there's a well-hydrated eye, and the eye shines when the light is reflected well, as is in this beautiful eye. Here you see dry eyes. You see that the light does not reflect well on the eyes. You need the lack of shine. And you know at the same time that the epithelia, not only the eyes, but that the mucosa of the respiratory airways are also thinner and dry. Here also the lips, these are well hydrated lips. There's no deep cracks. Here are lips that stay in a excessive air dryness. So in the winter, when you heat and you don't put humidity, that type of lips, that's what you have. And then you will have easier the flu. So why? And the COVID-19. So dry lips, cracked, fissures, sore. So there are key regulations. This is, of course, just a little things taken out of a greater presentation with a lot of good structure and a lot of interesting information. You go from one slide to the other, well, you get some trembling, I would say, in your stomach of excitement. So there are key recommendations to avoid get contaminated. I'll give you, but of course the details go to session 1 for that. Put a mask on, preferably a class FFP1, that's European standard, or N95, American standard respirator, or a high class of those, because it is much more efficient. Keep a distance. If you wear a mask, the distance is 1.50 meters, so a little bit more than a yard and a half. But if you don't wear a mask, there could be the microbes can spread, the coronaviruses and bacteria can spread up to 9 meters. So then you have to stay at 30 feet distance or 9 meters distance if you don't wear a mask on. So the social distancing that they say at 1.5 meters is only valid if you put a mask on. Avoid being polluted, avoid being a sick building syndrome. Some buildings are indoor with materials that are not good, like plastic vinyl, for example, outgases, and you get sick from it, or wood that has wood preservatives and get also sick from it. So don't put that. Also, some clothes can be toxic. They put anti-mite, they spray anti-mite products on it, and that makes you sick. Increase the room temperature to 25-30 degrees Celsius. Actually, you even can increase more, but then you get tired. But by increasing more, you get less infection transmission. Optimize the room humidity to 50% relative humidity. Disinfect your hands and arms, but we will see it's maybe not with an antiseptic, but with a probiotic. Think outside of the box. We have to think new things that are healthier and more efficient, and often the two go together. Do not smoke. You know that is something not good, but it will also show data that shows you why. So also the diet, what helps and what hinders. Drink water is extremely important. Many studies show that it decreases inflammation. But you have to have good hydration, because you saw that those respiratory therapy in dry outdoor air, but also if you don't drink enough, they get too thin, and then viruses and bacteria can pass the epithelium and go inside of the body. So here, for example, insufficient water intake, what it was is that there was a greater in nursing home. They often don't drink enough. Often these people are dehydrated for many reasons. They don't think about drinking water, or they have some urinary incontinence, a bit afraid of getting that. But the result is, if they don't drink enough water, they have a higher 14-day mortality when they have lower respiratory tract infection. Lower respiratory tract infection, that's pneumonia, that is tracheitis. So those more severe infections, they will die easier from it if they don't drink enough water. They also use 2 times more antibiotics, meaning that they get more infection, those people. And well, no, it means that there's 2 times more mortality with antibiotics, but 7 times more if they don't take antibiotics, those who don't drink enough. So if you want to keep living, drink water, drink enough, at least 1.5 liters, if not 2 liters per day. And it's not coffee that you need to drink, because that dehydrates you, it's water. And the insufficient water intake also increased the mortality after 14 days. And 4 times more when they take antibiotics. So basically, also you should consume protein-rich foods. You know, the Sendai virus gives to small children, various babies, viral pneumonia, the pneumonia due to Sendai virus, and that it can be deadly. So researchers have searched what could they do to decrease this. And they thought maybe we need to increase protein intake. So they tried a protein deficient diet to mice, and they inoculated them Sendai virus so they could get the pneumonia, and they got the pneumonia. But those who were given a protein deficient diet died earlier. You see it here, the red on the curve, the graph, 20% protein deficient, 2% protein deficient diet, a big mortality. While those who had a 20% protein rich diet have actually an excellent situation, 90% continued by surviving the Sendai virus. So when you are on a protein deficient diet, the researchers found that you need 1,000 times less of the Sendai virus inoculated to get actually a lethal dose, the 50% lethal dose, where 50% of the animals die. 1,000 times less. So sensitive are protein deficient mice. Avoid bread. Everybody says healthy, I take whole grain bread. That is a joke. Whole grain bread is not good. It's not sprouted, so there are enzyme inhibitors in it. So it's very difficult for digest, but it's also not good for the sex hormones. You lose sex hormone. The levels go down in the blood and they go up in the stools. The mechanism I can tell you in another talk, but for the moment, focus, that is not so good. But it has another problem, is that bread actually stays in the intestines. Rottens, if you want, in a certain sense. And what do you have when bread rottens in a certain sense? You put it in water, plastic bag, put at 37 degrees Celsius, the temperature of our body, and you put some water in it. That's like in the intestines. They get yeast. So you get easier yeast. And so in this study where the woman had Candida vulvovaginitis, the Candida of the genital areas, there were 22% had a recurrence episode. And the researchers want to know why. Well, the factor associated with recurrence, almost the most important factor, was ingestion of twice per day or more servings of bread. So if you love bread, well, maybe that's the reason, if you're a woman, why you have Candida genitally. Use also effective environmental microorganisms. I skipped here a lot of information that we have in the first model, but I had to make a choice. So sorry that I cannot give you more, but basically use effective environmental microorganisms. And this you need to listen. Our world is not a world of humans. Our world is full of bacteria and other microorganisms. There's so many more than humans on here. And half of those bacteria die every 2 days. But there's a renewal that is really impressive. And you can use good probiotics, because the good probiotics are not only necessary, that's the gut bacteria, for our intestines, they are necessary also for our environment. They are necessary for the outdoor environment and the indoor environment. So what I do is I have a little device to spread my probiotics, and regularly I spread probiotics in my office. And when plants go sick, you can spread probiotics. And that is a researcher in Japan that has become famous for finding an ecological way to be more efficient. And he developed a whole set of microorganisms that go together. The trick is not taking one microorganism, just one, but mixing a lot of different, and together they can make that plants, outdoor plants, grow better, that indoor plants grow better, that you can clean the floor and furniture with those multiple probiotics. Don't forget, it has to be multiple probiotics. And he designed several strains that are better than others. You can even wash your clothes with multiple probiotics to improve cleaning. You can spray multiple probiotics on hands to clean them. So we don't need antiseptics, or not as much as before. What we need is probiotics to clean our hands. You need water and probiotics. And then the good probiotics actually can kill the bad bacteria that might be, or the bad viruses that can be on your hands. Add multiple probiotics to the wastewater so that you don't put soap that is so destructive for the environment. So that was the first session. Now let's look at the second session, where we'll talk about nutritional supplements to improve health, and specifically the resistance against infection. And so in this talk, I will talk about zinc. And zinc, we will see, we'll always have a little overview of how the patient is when there's zinc deficiency, and how the patient is, for example, when there's zinc supplementation. So with zinc supplementation, you have this boy that had very thin and sparse hair. The hair got thicker and stronger. And here you have, for the zinc deficiency, widespread skin scaling, typical for severe zinc deficiency. And look what happens with the skin when you give zinc supplementation. It's much better. And also with wounds, when there's not enough zinc, the wounds have difficult repairing. They heal slowly and difficultly, and easily get infected. That's a sign of zinc deficiency, when wounds get infected. And zinc supplementation, see how quicker it is. And this is in 7 days. So it's much quicker when you give zinc supplementation when you have a big wound, for example. You should also, of course, take enough zinc so that you don't need to add an additional one. You're having enough. Now, on these wounds, if you don't want to get them infected, you don't need to put antiseptics. You put probiotics on it. If you have a good solution of probiotics, it often works better, and they will also stimulate the wound healing. Zinc deficiency facilitates. We also have throughout the course overview slides like this, where zinc, we showed that zinc improves viral infection, and there's studies on the coronavirus, rhinovirus, influenza virus, respiratory syncytial virus, herpes, the herpes viruses, the hepatitis viruses, HIV also. There will be a lot of focus on HIV, because I think there's so many tools we have already now with nutritional therapies and hormone therapies for AIDS, that it's always a little pity that they are not more used. Bacterial infections also, there's a lot that can be done. Even tuberculosis can react better. Salmonella and Streptococcus, etc. And also yeast infection is also efficient for Candida to fight off. And parasite, a lot of parasites respond, even leprosy. And but leprosy is not parasite, it's actually a bacteria. So it's in the wrong column here. But anyway, what you see here is that zinc looks omnipotent to improve the immune system, to resist to almost any type of infection. And that's what you need to remember. Here, each time we got in contact with people that were suspected of having a problem here in the family and in our office, we took increasing doses of zinc and vitamin D. Vitamin B will be also next one. So zinc decreases the common cold, for example, 42% quicker that time to get over the cold. But we will discuss also that with people who are cortisol deficient, if they increase their dose, within 2 hours, they're rid of the cold or they're rid of the flu if they start very early. So there are a lot of different tools that can help. Zinc improves the immunity of HIV patients. We see, for example, this is the slow decline in many HIV patients of their CD4 count. The CD4 are T helper cells that are necessary for your immune system. They go on the places of infection, and there they stimulate other cells to be active. Well, those cells decline very much. The normal level is around 800, 900, and declines slowly up below 200. And here in this study, they want to see if zinc could help. So they give a very small dose, 12 milligram per day for women and 12 milligram per day for men of elemental zinc, so really zinc, for 18 months. Okay, so they were sure they had enough supply of zinc to not have a deficiency. And what happened is that it decreased by 76% the incidence of immunological failure, of going down below the 200 cells per cube millimeter. And we have a lot of other tools, also other hormone therapies, the nutrients that can also help to keep the CD4 cells higher. Vitamin A. Vitamin A here for respiratory infections, if it's supplemented with vitamin E, here a study in China, 1-year double-blind study showed that when you gave every 2 times a year, 200,000 international units of vitamin A and 40 international units of vitamin E, which is extremely small dose there, well, you had more than 3 times less respiratory infections. And that's the type of infections that affect most of the children. And there were 7 weeks after the first supplementation, you could already see there was an increase of the serum IgA. What is IgA? Those are the immunoglobulins, the antibodies that defend the mucosa. So in respiratory infection, go through the mucosa. And so let's look at vitamin A supplementation in AIDS. Here it actually concerns newborns from mothers who were HIV infected, were infected by the HIV, got pregnant. And you could see that those who were PCR negative at baseline, but became PCR positive at 6 weeks, so positive for HIV, became infected after birth or at birth, they're giving vitamin A supplementation to newborn decreased by 28% the mortality. Those who were already positive at birth, it had no effect on those, but of course, because you give the vitamin A to newborns when they had already the infection, so it's a little difficult to prevent the infection when you have it already. But just so that it does give an interesting effect. And here we have vitamin C. And vitamin C on sepsis is really a vitamin I like. So patients had sepsis, that is just systemic inflammation all over the body. It goes in the blood, it can do very damaging, and the patient has to be hospitalized. They gave it to these patients that had difficulty breathing, acute respiratory distress syndrome, that was for less than 24 hours, so they intervened quickly. That is actually the important information, is that when you intervene with something that can help, do it as quick as possible. It's much more efficient then. It is also for the case of vitamin C. So intravenous infusion of vitamin C was given. On the average, it's like 6 grams per day, but and it increased the survival by 31%. 70% of the patients survived in the group with vitamin C, and only 54% in placebo. So you could see it here. Intravenous infusion, you see gradually on the graph the lower mortality with intravenous infusion. Is the curve in orange brown. And what is interesting, and that is really what fascinates me the most, is how do you think that people with sepsis die? From the temperature? From the weakness? They die from a multi-organ failure. The heart is not good. The intestines don't work well. The lungs don't work well anymore. Why? Because all those organs don't get enough oxygen. Because, and that is important for all medicine, is that the capillaries that surround these organs are closed. The small blood vessels that give them the blood are many of them are closed. And vitamin C is exactly something, one that can open up the capillaries by stimulating the secretion of nitric oxide, and that opens up the capillaries. So there's much more blood supply to all these organs. Now, here's the thing. When you have a problem locally and it doesn't cure an organ that doesn't work, it is generally because the capillaries are not open. So go and look through the literature, everything that can open the capillaries, and you will probably get rid of it. And one of those things is giving high amounts of vitamin C. There's other things. We'll see that also. Further, vitamin D, the vitamin here on survival, we know that actually if you're in a lowest quintile actually, and here of the curve, your vitamin D level is between 0.9 nanograms per milliliter. You actually have twice the mortality you have when you're at a higher level that is above the 35 nanograms per milliliter. So here on the graph, what you see above the 35 nanograms per milliliter, it gets stabilized. So you need to be about 35 nanograms. What is the lower limit of vitamin D in your lab? 20 or 30. So even if you're within the reference range, it's not safe. So here's the holes. Here it is good, way in the green zone, above 35 nanograms per milliliter. Now, what about the SARS-CoV? Well, you're going to get some cribbles in your mind or in your heart or in your intestines. I don't know, but look, this is a very recent study published end of August. 76 patients were hospitalized with COVID-19 infection. So if they get hospitalized, already severe form of the infection. And the researchers in Spain decided to give 50 patients to treat them with oral calcidiol, and that's about more than 2,000 TASH units. And basically, what happened is that only 2% required admission to intensive care unit. And they all survived without complications. But look on the right. Those who were not treated with vitamin D and also got in hospital, 50% of them, and not 2%, 50% of them required intensive care unit admission. So they were sicker. And there was 8% mortality. 2 have died of that group of 26. And probably it could have been avoided had they taken vitamin D. So high dose of calcidiol, it's not really a high dose, but okay. I give 10,000, it was a little more than 2,000. That significantly decreased the need for intensive care treatment, meaning that it made that the disease was less severe, and it decreased the severity of the disease. So simple, not expensive, and you save the life of people and they don't get the severe form of COVID-19. Vitamin D also can inhibit HIV replication, and one of the ways it induces it is that in vitro, when HIV go into macrophages, it stimulates autophagy of the macrophage. The macrophages eat themselves up, if you want, and they also die from the process. But by doing that, they also kill the HIV. And vitamin D reduces acne. Let's look at here first that patients with vitamin D deficiency that are below 20 nanograms per liter or 50 nanomoles per liter, they have twice more risk of having a Staphylococcus aureus infection that resists to antibiotica. And when you give vitamin D to patients with acne inflammatory lesions, what you see is that the oral vitamin D improves the skin at just a small dose of 1,000 international units per day. And that significantly decreased the inflammatory lesions. But if you give more, you probably have more efficacy, because vitamin D is very anti-inflammatory. And what about tuberculosis and vitamin D? Well, here's that you can inhibit with vitamin D 125. That's an activated form of vitamin D. It's calcitriol, sulfatriol, that inhibits the growth of Mycobacterium tuberculosis. And it does this, why? How? By stimulating in macrophages the secretion of proteins that actually are very aggressive for those Mycobacterium, and also by stimulating, as for the HIV, autophagy in human macrophages. So two mechanisms that make it hard for tuberculosis to survive. Now, what about iodine? Iodine is one of my favorites. It inhibits coronavirus replication. On surfaces, it's probably the best disinfectant. And here's an overview that compares it to chlorine or alcohol or chlorhexidine. But you see one thing here is everything in yellow here. Look well closely. Iodine is as good as the others or better. And it is good for bacteria. It is good against viruses. So really, it is omnipotent. And I will talk about a study that is will probably fascinate you. It's very anecdotal, so sorry for that. But it's a cat with AIDS, was dying from AIDS, completely, almost the last stage, and the people gave him all of his owners gave him a lot of iodine during 6 weeks or 8 weeks, not sure about exactly, and completely recovered. 5 years later, there was no trace of HIV. So that shows you how potent and how safe it is to take iodine. And okay, so let's go. And the third session will be about thyroid and thymosin alpha-1 supplementations and how they act against infection. And so first, we'll talk about thyroid therapy that is actually an overall immune enhancer. This is why it's the first hormone I will talk about. It stimulates the whole immune system, also by stimulating all the other hormone productions, almost all. And we'll have overview graphs like this, like low serum T3 and T4, decreased immunity. It is when you have lower levels of T3 and T4, you actually get a thymus atrophy, less thymocytes in the thymus. And you also have lesser lymphocytes when there's low thyroid. You also have lesser CD4 T lymphocytes, lesser cytotoxic CD8 cells. So all these T lymphocytes that are important for immune system go down. There's less production. The whole body gets lazy. Also, the production of all those immune cells. There's ratio CD4 CD8 that is so important also goes down. There's less IgA antibody levels. So mucosa are weaker because they don't have their antibodies locally to defend them. The IgM antibodies are lower. The IgG antibodies are lower. So there's a B lymphocyte activity decrease. The natural killer cells go lower. A lower number of natural killer cells and lower cytotoxicity. They are not so good. And there's apparently some studies show that no association with these CD4 and CD8 cells, but we do have studies that do show an association and think that this is a very, very good immune booster. So what happens in untreated congenital hypothyroidism, so babies that are born hypothyroid, is that they have actually low levels of the antibodies, low serum IgA that could protect them against respiratory infections and intestinal infections. And they even have a very high frequency of undetectable levels. There's almost nothing found. You need thyroid hormones for EGA. And they also have lower levels of IgM, so they cannot react quickly to an infection. And the lower the serum free T4 is, the lower the serum immunoglobulins is, lower IgA, lower IgM. So the more severe the congenital hyperthyroidism, the lower those antibodies are. Shows you how important it is to have a good levels of thyroid hormones. Now, natural killer cells are about 10 to 15% of lymphocytes and 10% of the peripheral blood mononuclear cells. And we see in non-Nigerians, people who are 90-year-old or 90 years or older, that they have a serum T3 and T4 that is actually related to the number of natural killer cells. Natural killer cells are cells that kill viruses and cancer cells. And you see the serum total T3 here, the red here on the left. You see that the higher the serum total T4 goes, the more natural killer cells is. And a small difference in T4, you're going to increase it by, let's say, you're going to double it. Well, you have 5 times more natural killer cells. 5 times more natural just by doubling the level. So if you just increase by 20%, you might have 2 times more natural killer cells. Small change, big difference. And also we see that the higher the serum free T4 is in these patients, also the more they get a higher number of natural killer cells. Now, what does thyroid hormones do on the coronavirus? Well, let's say what happens in COVID-19 infected patients is that they get lower levels of T3. That's the most important hormone. I will constantly repeat that the most important thyroid hormone is T3. And we have a lot of studies that show how important it is to keep a good level. So if you only ask T4 in blood, you're probably missing a good point. So 56% of patients who are hospitalized with COVID-19 have a low serum TSH, not a high, and below the normal range because there's viruses attack the pituitary gland and they make it malfunctioning, that it doesn't secrete enough TSH, enough growth hormone, enough and all the ACTH, etc. That's typical for viruses. For the flu, dramatic decrease of ACTH. Here, there's also a decrease of TSH. So it's not that they have too much thyroid, it's that they have too low because the T3 is actually too low in these patients. And the lower the TSH and total T3 are, the more severe the COVID-19 is. It's really a positive association. So think about the thyroid, they need to be substituted. After recovery, there was actually an improvement again. So it is related with the disease, but it also keeps the disease going on if it's too low. Thyroid hormones on herpes zoster. That's the herpes that is so painful. It's caused by a virus that looks like this, the herpes zoster virus. And you see here, there's it usually is one dermatome that is in one, you see here the nerve part that is affected, and it's then just in one region that you have it. And you only have it in people who had the smallpox, the chickenpox, who had varicella. And it's a reactivation of latent varicella infection. And you had to have previously chickenpox. And its latency, it goes in the dorsal root ganglia here to reactivate as herpes zoster or shingles in single unilateral dermatome generally. So it's painful skin rash with blisters in a localized area. That's how it looks like. So that sort of infection is more frequent in older adults and more frequent in hypothyroid adults. And when you give a thyroid treatment to hypothyroid patients and they get euthyroid, like this patient, you see the difference. She's swollen, hypothyroid clearly, and then she gets slimmer euthyroid with thyroid treatment. There's 40% less risk of herpes zoster. And it's significant in all age groups except the younger age groups. There may be other parameters there, but a treatment that gives 40% less risk of herpes zoster is an interesting treatment. Even more efficient in hypothyroid women than hypothyroid men. There's a greater decrease with the hypothyroid treatment. What about thyroid and viral hepatitis A? Here also, thyroid hormones are important to decrease the risk of having this disease, hepatitis A. So when you add thyroid treatment to the patients with viral hepatitis A, there's a quicker and better clinical improvement of these patients. They have a better liver function, their immunity is better, and hormone status will be better. And so it's recommended for wider use in patients with viral hepatitis. So you can do a lot against infection and a lot to prevent, and try to prevent rather than wait till you or your patients have a problem. Thymosin alpha-1 is probably the most powerful immune stimulating hormone I know. And how do you treat with it? That will be explained. We'll always explain practical things like, for example, thymosin alpha-1. And you don't use the sterile water it's delivered. You use bacteriostatic water, so it holds on longer. You mix it with something preserved, because the way I do it is not use a whole vial on one day. Is spread the dose every day a little bit, works much better. You can then use lower doses in general and will be less expensive. And you inject it subcutaneously, the thymosin alpha-1. And the dose for prevention is between 0.03 and 0.05 milligrams per day. So with one vial, you can have actually enough for 30 days or 50 days, depending on if you take the lower or the higher dose. And it's then much less expensive. And then you can increase to a double dose or a triple dose if you have an acute infection. And if you're very quick, within 1 day it goes away. Even if it's the flu, COVID-19 or pharyngitis, COVID-19 is more 2 or 3 days, but basically it goes away very quickly. But be quick. The quicker you are, the better it works. In allergies, it also works. It's very anti-inflammatory. It stimulates the immune system, but decreases inflammation. Exactly what you need. I have the impression that hormones are intelligent, because they stimulate inflammation when you have an infection, and they calm down inflammation when you have too much inflammation. So they seem to know what to do. It's very strange. I have studies really that show something that we would be surprised. Like they have a certain intelligence. I don't know why, but it looks like. So where do you inject? You inject there around the belly, on the sides of the thighs. There are other places that we'll talk about, but these are the most common ones. And you see here how to inject. You always inject subcutaneously, oblique-wise, 45% angle. And you don't pinch the tissue. You extend the tissue, so the skin gets thinner. It's easier to get through. And there are life-threatening acute infections. Can you use thymosin alpha-1, intravenous infusion? Yes, so when it's life-threatening, you can increase the dose, and you might have to increase up to 11 milligrams per day during 7 days. So there's no upper limit. There's no toxicity of this. There's no side effect when you take more. The more you give, the better it works. So for the coronavirus, this is the treatment that gives the best efficacy. It did increase most of the mortality of severe COVID-19. So we don't have a treatment. We do have, this is a fantastic treatment. But I must say they gave 10 milligrams a day, subcutaneous injections of thymosin alpha-1 for at least 7 consecutive days to the patient. And what happened is that we're 3 times lower mortality, 3 times. Only 11% of those patients died, while 30% died in the non-thymosin alpha-1 taking group. And the researchers of China that did the study were even more intelligent. They took it themselves, and none of those who had took it got infected, at least at the time of the report. So there was also 80% less need for non-invasive mechanical ventilation, and so it took out the need actually for invasive mechanical ventilation. None in the treatment arm were intubated. So let's overview the thymosin alpha-1 effects on treatment. It attacks all these viruses you have. You have here the references in short. Cytomegalovirus also, herpes simplex, influenza virus, coronavirus. Some are only in vitro studies, some are studies in mice, but when it's not indicated, it's studies on humans. And here bacterial infections, efficient for bacterial infections, including Mycobacterium tuberculosis and Pseudomonas. And yeast infection, also interesting against yeast infection. There's parasites. I didn't find any study. And it also helps for infections related to acute pancreatitis and sepsis, etc. So it's very omnipotent. This is really my favorite for immune system. And then we'll see in the course infection 4 on cortisol and DHEA, the crucial immune enhancer. Without cortisol, the immune system doesn't start to get into action. It's the immune resistance stimulation by the thymus depends on the adrenal glands. Especially physiological levels are good. Here's an overview of all the effects on cells. That physiological dose of hydrocortisone, when it's given, will increase the neutrophils, not the opposite. Will increase their activity, will increase the macrophage activity and dendritic cells, which are also macrophages, will actually increase Treg cells so that you have less autoimmune disease, will increase the B lymphocytes and the antibody production. So it's a really immune booster. You'll have more CD4 cells, which could be interesting for HIV patients. And so the monocytes, and we have here cortisol and ACTH, they increase the macrophage number and activity. Has been shown in a very old study in 1947. Just wanted to show you that I'm not going to base my talks only on the most recent update. There will be extremely recent update. We have seen already for vitamin D, for example. There are many others. But we'll also take some of the good studies up below that give an information. And neutrophils, these are neutrophils, those round cells with polymorphonuclear cells, different a lot of the strange nucleus. And we see here that hydrocortisone and prednisolone can increase the neutrophil count. You see that physiological doses or even supraphysiological, you always increase the neutrophils. There's maybe a slight decrease in the beginning, and then it jumps up at higher amount. After a few hours, you get higher levels. And the higher the amount of cortisol given, like 400 milligrams, which is very high, the more it is. And okay, so prednisolone, but not bioidentical hydrocortisone, decreases the neutrophil cytotoxicity, meaning that it is better to use bioidentical hydrocortisone often than prednisolone. Although I must say that are uses that make prednisolone superior sometimes in infection inflammation for a short time. So we'll talk about those cases. So to increase neutrophil activity and number, use physiological dose of cortisol and use the bioidentical one, hydrocortisone. And can hydrocortisone prevent thymic aging? Here you have repeated injections that are given to mice. After a week of hydrocortisone, there's a thymus atrophy. That's what you expect, okay? But after 5 weeks of 12 hydrocortisone injections in total, the thymus is enlarged. Their cortical volume, the cortex is bigger, and there are more cells in it, more thymocytes, and there's a better profile of CD4 on CD8 cells, thanks to physiological dose of hydrocortisone. In the range, in those values came in the range that characterized younger mice. So hydrocortisone suspends thymic involution with age. That was the conclusion of the researcher. So T lymphocytes. This is the sleep-wake cycle. So you see here, cortisol goes very high in the morning when you get awake, and then when you start sleeping, there it goes very low. So you're able to sleep. Well, what happens is that parallel to that, and influenced by the cortisol, is that you have higher levels of CD3 lymphocytes. That all the T lymphocytes are CD3. It's a surface receptor named CD3 that is on their cells. And the CD3 that have CD8, so the CD8 cells, it's called, they have the two surface receptors, those are also increased. And they have strong cytotoxic cells, but also cells, part of those cells are immunosuppressive cells that suppress autoimmunity. So basically, when you have an autoimmune disease, you always need to have cortisol to boost those suppressive cells too that are healthy if they are balanced with other cells that stimulate the immune system. And when you look here, when at the lowest levels, they also are lower when cortisol is lower. It's really parallel. They depend on cortisol to be there. So a significant positive correlation of CD3 and CD lymphocytes with cortisol. The higher cortisol is, the higher these levels are. Cortisol also stimulates the immune resistance against infection, and we know this because Addison's disease patients have more infection risk. And these were patients that were treated with glucocorticoids, so cortisol or hydrocortisone or non-bioidentical ones. But the problem is, what I see is that those patients often have a too low or too high dose, depending on the physician and they never receive DHEA, and they should, so it's not well balanced. So anyway, they have high infection. It is known that these patients with or without treatment have higher infection rates, 2 times more lower respiratory tract infection like pneumonia, and 4 times more gastrointestinal infections. You know that people with Addison's disease, cortisol deficiency, actually complain a lot of colitis, gastroenteritis, etc. Because everything inflames. It's the anti-inflammatory hormone. When you don't have enough, it's not well balanced, woof, everything inflames, including the intestines. Even the urinary tract inflames and gets infected, 1.5 times more urinary tract infections. And they take also more antibiotics. And you see that these are tables that are published about meta-analysis of studies. It shows more lower respiratory infections, urinary tract infections, gastrointestinal infections, and more use also of anti-yeast products than normal. So it is important to know that when you begin an infection, and if you have healthy adrenals, what happens is that your pituitary adrenal axis if it's normally responsive, it will make more cortisol in the beginning. And so it's stimulated. And if you have a more severe infection, you get even more cortisol. But if you already don't have enough cortisol in the beginning because you're adrenal deficient, then you cannot increase enough. But it's known that for a good resistance, you need a boost of cortisol in the beginning of the infection. So what I do is plan A. When I get an infection, I have a little bottle with me that I have here, that has cortisol in it. And if I have the first flu signs, sore throat, inflamed red eyes, flu-like fatigue with low blood pressure, ear infection, I take a supplement, 5 or 10 milligrams, depending on intensity of what I have as a problem of infection. And every half hour, I increase a dose. So I take a quarter of a tablet or half a tablet, and I add, when I have it in the bottle, sometimes I don't have, but I try to have it in the bottle, also equivalent amount of DHA. And then within an hour or two, everything disappears. I mimic what my adrenals cannot make anymore. My age, or because I'm deficient anyway, whatever the age, I cannot make that extra boost. Well, I add it, and then it goes well. You could also do it with prednisolone, 2.5 milligrams. It stays longer in your blood, so it has sometimes a better effect this way. And also with 10 milligrams DHA every 45 minutes, because it stays longer, so we do it every 45 minutes until there's appearance of flu signs. And you won't get overdosed because the body needs more at that time. It consumes more. So don't exceed 3 hours of additional cortisol take. So all those things will be explained. Also plan B, etc. will be explained what to do when you already have, since 1 or 2 days, the infection, you forgot to increase the dose. So how quick does the flu disappear with these early cortisol supplements? Well, within 2 and 4 hours, it gets over. Key info is the sooner you start with supplementary cortisol, the more efficient it will be. So cortisol and the immune resistance against coronavirus infection. Well, you know, when I put a slide like this, you probably already know the answer, is that it's going to help survive the COVID-19. This is a very recent study in September this year now. And 101 patients had no cortisone, 33% mortality. And they necessitated organ support. Patients here receiving hydrocortisone intravenous constantly every day, not adapted to the needs, just every day and even a high amount. 9% less mortality, which is not bad, and 2 times more days, 3 days of where organ support was not necessary. And then if you gave the cortisol upon necessity, if there was too low blood pressure, for example, shock was clinically evident, 21% lower mortality and 60% more organ support-free days. So it's better. And there's another study on dexamethasone, a synthetic derivative, that even had better results. But we'll talk about that in the session on it. DHEA on Coxsackie virus to show, DHEA first in general, when you give 50 milligrams to age-advanced man of 63 years, exactly my age for the moment, well, what happens is that after 20 weeks, you activate the immune function all over. Not after 2 weeks or 3 weeks. It takes time with DHEA, 3, 4 months, 5 months, 6 months, ideal to see. There were no changes in the number of T cells, CD3 cells, but there was a functional activation of T lymphocytes. They were more active. They were more responsive to stimuli, and they secreted more cytokines, etc. Just more active. Same study showed also in men that the natural killer cells were activated. The cytotoxicity was better. There was a lot of very interesting information at that. The whole immune system seemed to improve. There was more monocytes. Here in animals, you can see the efficacy, and you will then learn something more, is not only the high mortality when mice are infected with the Coxsackie virus, but the situation is much better when you give DHEA to these mice. But look below. There's a line below of another product that was given where there was no mortality. The Coxsackie virus gives after 6 days total mortality, 100% die of those mice, and where none died here in the green zone. And what is it? That product is androstenediol gluconide. It's a metabolite of DHEA. That metabolite, you produce huge amounts if you inject subcutaneously DHEA under the skin, because it's in the skin that it's made. You have enzymatic equipment. And androstenediol is 100 times more potent to protect a mouse from dying from an infecting virus, especially the Coxsackie virus before. Now let's look at the 5th model on infection, and there we talk about melatonin therapy, growth hormone, estradiol, progesterone, testosterone, vasopressin. All these therapies have efficacy for infection. So let's look at melatonin and infection. Here again, your attention, please, and your respect. Your respect for melatonin. Melatonin is a 3 billion year old immune protector. It's in all life forms, all over the planet. Any bacterium, any life form that has been investigated for melatonin has been found. And we know this because fossils of a bacterium that still exists now and has melatonin, those fossils, we found fossils that are around 3 billion year old. You see here that 2 milligrams per day of melatonin increased the natural killer cells in young adults. That's good, more than 2 times. Melatonin also inhibits HIV. It increases CD4 counts in AIDS patients. You see here that the amount, there was 30% more CD4 counts in 1/3 of the HIV patients that took melatonin. So it doesn't seem to work in everybody. We don't know exactly why, but maybe those who had the greatest deficiency in melatonin are more responsive. Melatonin also decreases sepsis. And what can we do for septic newborns? Because 30% of them die. Very simple, cheap. No, not expensive. Give them melatonin. Here you see in these, there were different groups, and there were 2 septic groups, and in one group they gave 2 times 10 milligrams at 1 hour interval. So just a sort of big dose. But melatonin is not dangerous, it cannot kill, so you can give a big dose, even to a septic child. So very high dose for such a child. And what you see is there are much less lipid peroxidation products, because that means that actually means that the membranes of the cells are in better state because they are not aggressed, because lipid peroxidation come from damage to the cell membrane. So all the cell membranes of those babies, the cells of those babies were better and improved the outcome after 24 hours and 48 hours. And after 3 days, it blocked mortality, where none of those 10 children that received melatonin died from it, while 30% in septic controls. And you know what? I don't think it's used. It's a study of 2001, and nobody pays attention. Nobody pays attention, because this could be also help adults. There's no danger to take it. So if it doesn't work, it doesn't work. But you're not going. There's maybe a little thing is that in sepsis, if a person has too low cortisol, melatonin can further decrease the cortisol. So you should give melatonin like you should give growth hormone in septic patients, always with cortisol, so that you keep good cortisol levels. What about female hormones, estradiol? This is also amazing. We know that women in postmenopause have a very thin mucosa at the vagina, so it's thin and and when you give female hormones, you really give a better maturation, and you increase the superficial cells, the intermediate cells, and the parabasal cells go lower. They decrease. And the vaginal pH will decrease from 6.2 to 4.5. That is actually 80 times more acid. So in an 80 times more acid environment, how can bad bacteria proliferate? So you're protecting also against infection. And you have more Ki67 positive cells. There are cells that actually have a protein that is a marker of a new cell and that divides easy. And you see this difference between the menopause, where there's a very thin vaginal mucosa and the very thick vaginal mucosa of a high estrogen environment. So we need to give to women female hormones to protect them from HIV. Here's a study. Female macaque, so these female monkeys were had a removal of the ovaries, and they were inoculated inside of the vagina with HIV, or the simian equivalent, the monkey's equivalent of immunodeficiency virus. And those who were treated with estrogens, actually none was infected. While those who were treated with progesterone, almost all of them were infected, 83%. And those who were not treated, when they had in the vagina the inoculation of this virus, all became infected. Now, the vaginal subepithelial inoculation, no, I'm going to show this rather. You see here, there were, this is the vaginal lumen above on the graphic. And then below you have the vaginal epithelium. And then below the more darker purple zone is subepithelial, the subepithelium, the tissue below the vaginal epithelium. And actually, when you inoculate inside of the lumen of the vagina, you cannot inoculate an estrogen-treated monkey. But if you you go through the vaginal epithelium and you inject in the subepithelium tissue below it, then you can get infection. And so this means that it's actually a thick vaginal epithelium that actually protects these wounds of being infected. And this is when you saw the study on the hamsters, where 1/3 of the hamsters did not get infected by coronavirus because they had thick mucosa. And that is dependent on sex hormones and other hormones, but mostly sex hormones. What about growth hormone? Growth hormone is a super immune booster, but not in adrenal deficient patient. When there's cortisol deficiency, growth hormone can aggravate the cortisol deficiency. You always have to correct the cortisol deficiency in a person who's going to take growth hormone. And we see that in growth hormone deficient children, it increased the immunity, it decreased the lymphocytes, the CD3, CD4, CD8, and the ratio. So they really improved. They restored the IgM production. So it really is positive. It's not in all studies in children. So we'll talk a bit about that also in the lecture to get more details, how you can discriminate between where there's a risk or not a risk with growth hormone for the immune system. Growth hormone on HIV is that when you give the treatment to HIV patients, the CD4 T cell number generally increases significantly compared to baseline. Here, for example, to know how much, well, about 15% more at week 36 and at week 60, so more than a year, 31%. What is the lesson here? Is that growth hormone works very slowly. It can take 1 year, 1.5 years to optimize the immune system with growth hormone. It doesn't work quickly. It can. There are possibilities, but then you have to be sure you have a good cortisol level. And you have to give a little overdose during several days. So also interesting is that IGF-1, growth hormone stimulates the secretion of IGF-1, insulin-like growth factor 1. IGF-1 can inhibit replication of HIV in vitro. So here, the HIV inhibition by IGF-1 was seen at physiological dose or even lower, very low concentrations. So you don't need much, but some older people have extremely low IGF-1, and people with AIDS, patients with AIDS, have even also very low levels. So you need to boost the IGF-1 activity. And so the half maximal response for IGF-1 was in the physiological range. And it inhibited the production by the HIV virus of a protein called P24 antigen. And interesting effects. What about testosterone infection? Well, testosterone may improve the outcome of the hepatitis C virus. This is really important. This I want to tell you because it's probably applicable in other chronic viral infections. Here we have patients who are hospitalized in the stage 3 or 4 fibrosis of hepatitis C. They have had a liver transplant, and unfortunately, they did a recurrence of hepatitis C that caused them to have the necessity of liver transplant. So they did a recurrence, and 5 patients remained without the testosterone treatment. No improvement was seen, and they all died within less than 3 months, or an average of a little less than 3 months. 9 patients applied the testosterone gel, and all of them stayed alive, no deaths. And they all benefit from significant improvement in albumin. So it means that they're not malnourished anymore. Testosterone was better, muscle strength was better, well-being was better, and then a typical disease activity score was better. So you see the difference. This is why we as health professionals have to pay attention to our patients and not hesitate giving the hormone treatments. There's enough science. If you go to all those sessions on video, you will get all the references. It will be a lot. And I'm giving you already a lot anyway, but I'll give you more, and you just have to be calm that it's not too much for you. So I try to make even slides less full just for you to have it easier. And so let's look at for growth hormone, what type of dosing you might need. Well, the usual dose is between 0.1 and 0.35 milligrams per day. What is dose I take? I take like 0.05 to 0.1 milligram because I started soon, so I don't need a high dose. But most people of my age need a high amount. If I would take a high amount, I think I would swell up, too much anabolism. So for prevention, the dose of prevention was good to have a good immune system. Now, if you do an acute or chronic infection, should you increase the dose? Generally not. But if you have a good cortisol function or you're taking a good treatment, you can try. You can try for 2 and 5 days to increase the dose, to take a double dose or a triple dose, and it may help. But you have to be sure you're not in cortisol deficiency. So we'll explain in the lectures how to recognize cortisol deficiency easily, etc. Now, what is typical sign of overdose of growth hormone? Swollen feet. It's really almost the first in everybody. So pay attention to if you have difficulties putting on your shoes, for example, you're taking too much. If you don't treat the cortisol deficiency, this is why I put it a little bit higher, you have to give 50% lower dose of cortisol for tolerance because growth hormone decreases the cortisol. So you might not tolerate the adequate dose. Vasopressin infection, septic shock, we'll see, for example, not only that vasopressin levels are lower. Vasopressin is a hormone that keeps water in the body. And that's, if you don't have enough, you have to drink all the time, but you have to go to the bathroom all the time and you're never, never have enough water. Well, the people with septic shock, they're very sick because of an infection. They're in hospital. Their blood pressure goes down. That's why it's called septic shock, the lower blood pressure. They need desmopressin, and they have lower levels, both baseline, about 40% lower. And desmopressin, when it's given, it can decrease the mortality up to 66% at 28 days. So again, a tool we have to make our patients live. Maybe not live forever, but live much longer. We shouldn't die in infection. In 2020, we shouldn't. And how many people are dying now for COVID? I bet we can boost the treatments. Aldosterone on septic shock. We'll see also how it works, etc. And then we go to our second module that is actually was the first session on inflammation, where we'll look on the dietary and the environmental factors that can cause inflammation. And also we'll talk what are the anti-inflammatory supplements that can be given. So, and what is important to know is that we need to have inflammation. It's our first protection when you have a pathogen going into the body. So we have to demystify that it's a danger. When the infection keeps on there, it becomes chronic or gets excessive, then it's not good. But that's caused by hormone deficiencies or nutritional deficiency or both. So acute infection proportional to the damaged tissue or aggressive pathogen is actually okay and beneficial. And we have to our defense pro-inflammatory cells like neutrophils, basophils, eosinophils, and also monocytes that become macrophages or dendritic cells. We also have a whole group of lymphocytes, including natural killer cells, CD4 and CD8 lymphocytes. And we'll talk in an easy way that it doesn't overwhelm you. Pro-inflammatory cytokines, we have interferon gamma, tumor necrosis factor alpha, and then a whole set of interleukins, and also leukotrienes. And we have also anti-inflammatory cells so that we don't inflame too much. And the balance is important. And if a person is too much inflamed, it might be because of a lack of anti-inflammatory cells. You have the immunosuppressive CD8 cells, the TREC cells, these are the regulatory CD4 cells, and then you have the Th17, the T helper cell 17. They are anti-inflammatory. And then you have anti-inflammatory cytokines, proteins actually, that calm down inflammation. And that's interleukin 4, interleukin 10, prostaglandin 4, 2A, brain-derived neurotrophic growth factor, epidermal growth factor. So many that will try to do it in an easy way, that you get accustomed it, that it doesn't look like enigmatic to you. And let's talk frankly also. What is the CRP? It's anti-inflammatory. Is that bad? Because the role of CRP is to detect and bind to what we can call unwelcome cells, damaged cells, cancer cells, or whatever. And it binds to, in the outer layer of the membrane, to sphingomyelin, myelin, and phosphatidylcholine. So you see, this is the in yellow here, the phosphatidylcholine, and in orange, the sphingomyelin. It detects when it's damaged. So it will bind to the damaged areas of it. And so if you have a lot of damaged areas on membranes of cells, there will be more CRP secreted. So if, for example, we'll see this, if you burn your food, you have a lot of toxic material that will go inside of the membranes, toxic fat, like trans fatty acids, that will go on those places and actually will show up as damage and will stimulate the CRP secretion. We'll see that a bit further. So stress on inflammation, interesting to see that stress is more important than the diet to increase inflammation. So this is a saturated fat meal and a meal with olive oil or sunflower oil. And you see that saturated fat meal, when it's too much saturated fat, there's increase the CRP, increase other inflammatory molecules in healthy women here. If one had before the day stressors, there was no difference anymore, meaning that the stress override, because the stress increases so much the CRP and so much the amyloid A and the other inflammatory molecules, that it's not the saturated fat meal that's going to make the difference. Water decreases inflammation. Water drinking is the first step when you are inflamed to calm down the inflammation. Here's a whole set of references: the purified water calming down the inflammation, healthy water calming down, mineral water calming down inflammation, thermal water, river water, hydrogen rich water. That's how to do hydrogen rich water. You look on internet what it means, but just put magnesium in water and you get hydrogen water. High protein diet also decreases inflammation. You see here that individuals took low carb, low fat, and mainly high protein diet had, after 8 weeks, significant decrease of the CRP and interleukin 6, the two major inflammatory markers. And that had a sustained beneficial effect, continued a year or more, as long as they continued on the high protein diet. What about a vegetarian diet? Well, a vegetarian diet in analysis of 18 observational studies didn't help, actually. It didn't help. Overall, no difference in serum CRP, even if you had a minimum duration of 6 months. It did help, however, when at least 2 years of vegetarianism. And I think one of the reasons is that when you start to be a vegetarian, you first do it badly, wrongly. You do it with a lot of carbs, not with fresh vegetables and fruits so much, but like pasta and things, and that's not being vegetarian. And you may take maybe a lot of milk products, which is not the best type of protein, etc. So I think after 2 years, individuals get much more towards the fresh food than the preserved food, and then that is probably the reason why it does work. Now, the advanced glycation end products are a problem. This is advanced glycation products. It's getting in fashion that is delicious to eat burnt foods. It's completely crazy, actually, completely crazy, because the proteins and the fats, they become glycated after exposure to sugars. And when you take a hamburger, there's always a bit sugar in it, and the glycation is facilitated by overheating. So hemoglobin A1C is actually an advanced glycation end product. It is a mixture of a protein with sugar. And so those glycotoxins like hemoglobin A1C can cause oxidative stress and inflame. So much more free radicals in the body. Inflammation, it accelerates aging. And you develop diseases like diabetes, kidney disease, atherosclerosis, Alzheimer's disease. So why would you eat like this? Why would you go to the hamburger restaurant and take the most toxic food? When I go to a hamburger restaurant, because it happens, I don't take the French fries. I do take the salad. I know it's in plastic and it's not the best, but it's still better. Those salads are much better than the hamburgers and the French fries. So those advanced glycation end products, also shortened ages, make you age quicker and inflame you more. So here's a study that shows you that the higher the advanced glycation end products you have in your blood, the higher the CRP is. It's proportionate. It goes higher with higher amounts of serum ages. And also, the higher it is, those advanced age products, the more there's markers of oxidative stress. So a diet low in advanced glycation end product actually decreases inflammation in patients who have a sort of pre-diabetes. So low dietary ages diet for 24 weeks, see the difference, 43% decrease in CRP. So why would you eat your toast? Huh? That's good, the toast. Phew. You have to have courage to eat the toast. A lot of courage once you know the science behind it and what it really gives. So harmless? Don't think so. It's full of advanced glycation end products. At least the one you showed there. What about chocolate? So good, the Belgian chocolate, yes, super in taste, but only in taste. Because chocolate inflames your body. It increases the secretion of interleukin 1 beta and interleukin 10 by blood mononuclear cells. And tumor necrosis factor alpha, which is quite inflammatory. The interleukin 10 has some inflammatory effects, but mainly anti-inflammatory. And very interesting, because there's a study that shows also something more, upon stimulation with Propionibacterium or Staphylococcus aureus. Those are two microorganisms involved in the pathogenesis of acne. And they also decrease the anti-inflammatory cytokine interleukin 22. There's a study that shows you that when you take chocolate, you have more acne. And it's probably, acne and inflammation probably through an increased secretion of these. So what about the nutritional therapies that decrease inflammation? Vitamin A decreased inflammation in this study, 25,000 tash units per day for 2 months. You had in patients with ulcerative colitis, you see this is part of the colon and these are ulcers all over. And that is calmed down by intake of vitamin A. It's the #1 vitamin for the mucosa. They had improved clinical response ratio, improved mucosal healing ratio also. What about vitamin B3? This is one of my favorites. And what you see here is vitamin B3 is given in a blood samples from 6 volunteers that had received also endotoxin, lipopolysaccharide, to stimulate the release of inflammatory molecules. And depending on the concentration, but you have interleukin 6, for example, the increasingly higher amounts of vitamin B3 lowered the interleukin 6 which is very inflammatory. So that is very good reaction. And what you see in blue are the serum reference range for vitamin B3 or nicotinamide. So it's exactly in the range physiological of vitamin B3 that you have this anti-inflammatory effect that is very strong. It is extremely strong. You have 1500 here, and there you have around a little less than 400. So something like 4 times less. And then for interleukin 1 beta, also major interleukin, you also have lower levels at the upper reference range, especially of vitamin B3, a physiological range. What about thermonecrosis factor alpha? Also very good lower levels with vitamin B3. So you should not be too low in vitamin B, you should be high normal. That's ideal to decrease inflammation. And then you see interleukin 8, which is also inflammatory, is also decreased in physiological range, and especially high physiological range to have good effects. What about vitamin D3? It decreased inflammation in ulcerative colitis patients. You see, 300,000, one injection of 300,000 test units of vitamin D decreased 3 months later, 33% the CRP, and 46% decrease in erythrocyte sedimentation rate. Efficient. For just one injection, 3 months later, you're still good. Coenzyme Q10 decreased inflammation. 7 days of 200 milligrams coenzyme Q10 here was given. And on the 7th day of the study, what we had was a decrease of the important anti-inflammatory tumor necrosis factor alpha and decrease of malondialdehyde, meaning that the cell walls of the cells are in better condition. They are not having lipid peroxidation, or much less. That means that coenzyme Q10 200 million improves all the cells of the body, not just 1 and 2. And the decrease also of in-hospital mortality in those septic patients to whom it was given. So again, you've decreased just with 200 milligrams a day of coenzyme Q10. So you make a mixture. With the information I give, you can make a good mixture to have the optimal situation. Not only to prevent disease, to cure it quicker. So doses that are given are on average in adults 50 to 100 milligrams, but in acute inflammation, I would go to 200, and you can even go in life-threatening suggest to 1200. There's no upper limit. It's like Thymosin alpha-1, you do not have side effects by taking too much because it doesn't exist too much. The more you give, the better it is. If it causes abdominal malaise, stop 2 days and take 50% lower dose, but this is more an information for vitamin D. What about magnesium? The higher dietary magnesium are, the lower the CRP is. And so you have here from 0.9, you go to at 400 milligrams per day magnesium dietary, elemental magnesium, you go to 0.2 milligrams per liter of CRP. So the second session of the second model of inflammation 2 talks about thyroid adrenal hormones and thymosin alpha-1. And so let's look a bit about thyroid treatment. These are, it shows that the higher free T4 is in blood, our thyroid hormone, main thyroid hormone, the lower the pro-inflammatory markers are. So you see CRP, ECAM, VCAM, albumin is then higher, so there's a better nutritional state. But you see the inflammation goes down, the higher free T3 is. And when you give thyroid treatment, for example, in patients who were diagnosed with primary hypothyroidism, what you see is that actually you have an improvement of inflammation. The interleukins 1, which is inflammatory, goes down. The interleukin 6 goes down. The interferon gamma goes down. The tumor necrosis factor alpha goes down. And interleukin 2, which is more, in some conditions at least, anti-inflammatory, goes up. So basically, you improve the situation. You also increase the interleukin-10 by 40%. And you double more or less the interleukin-1, interleukin-6, and interferon alpha. Well, you take 2 times less, I mean. That's what I meant. Okay, so basically, this is a study I published a long time ago on my patients who were switched from T4, thyroxine, to a T3 and T4 treatment, either synthetic T3 and T4, either desiccated thyroid. And basically, with the T3 and T4 treatment, those who had pain and inflammation in the joints, actually all of them, almost all of them improved. So of those, 40% of those had some pain in joints. Well, 28% of them, like 70%, improved. Cortisol treatment on septic shock inflammation, for example, it decreases inflammation, the cortisol, very much, that we know all. And interesting is that you had a 77% decrease in interleukin-6 with the cortisol. And basically, you also decreased the release of hydrogen peroxide by neutrophils, so they became less aggressive. While you still with cortisol preserve the phagocytosis of those neutrophils. So basically you decreased with the cortisol the harm to the body by decreasing the oxidative stress, but you increased the immune system, or at least you preserved it. It was, placebo was not good. Well, it went down with infection, septic shock, and it was kept with hydrocortisone. So it does not aggravate non-specific immunosuppression, but instead it improved innate immunity in the early stage of the disease. So DHEA also decreases inflammation, inflammatory cytokines and markers. And you see, for example, that here I'm explaining that if you have an acute inflammation, you need to increase the dose. If you increase at the same time hydrocortisone, and this coupled together works very well. Explain here in adults, doses between 15 and 30 milligram, on average 20 milligrams in women, 35 milligrams in men. And in chronic inflammation, you also need more to calm down the inflammation, but also to rebuild the tissues that have been damaged by the inflammation. So DHEA is really the protector when you use cortisol. What about thymosin alpha-1? Well, it's anti-inflammatory, and this on chronic obstructive pulmonary disease. Those patients, they cough a lot and they don't feel good. And 4 weeks of thymosin alpha-1 treatment improved breathing, improved immune function, and reduced inflammation. Exactly what you need to have in these patients. So then we're at the last seminar about melatonin, IGF-1, estradiol, progesterone, and testosterone effects on inflammation. And that IGF-1 is anti-inflammatory is impressive because there are a lot of references showing that. And let's look at inflammatory bowel disease. And we see that inflammatory bowel disease, the higher the IGF-1 levels are, the lower the erythrocyte sedimentation rate is. And when you take children with inflammatory bowel disease, you see that if you're in the highest 3 quartiles of IGF-1, you have lower levels of inflammation, like lower interleukin-6, interleukin-10, interleukin-17-8, and also other pro-inflammatory cytokines are lower, like lower serum interferon alpha, and they feel better, they have more energy, and quality of life is better. In adult patients with inflammatory bowel disease, it's also like this, that the higher serum IGF-1 is, the lower the CRP is, the C-reactive protein is. So basically, it's better for all these individuals to have high IGF-1 because they will have less inflammation. And testosterone on inflammation, testosterone is very anti-inflammatory on 2 types of tissue. Muscle and joints and tendons, super anti-inflammatory, and anti-inflammatory also on genital areas. So when you have some sort of inflammation that is persistent on the testicles, on the prostate, whatever, even on the penis, then you have to suspect that the patient has actually testosterone deficiency. Check it, and if you confirm it, give, for example, like here, transdermal testosterone gel, and that decreased the number of leukocytes in the semen that were signs of inflammation. It also increased sperma and motility and normal, and but basically it also cured the male gland infection in most cases. And I see this often with recurrent prostate infections, etc. You need to give testosterone. You have to watch out for one thing, two things actually: not too high estrogens, and don't drink alcohol. That's all. If there's too much high estrogens, we have to give an aromatase blocker with the testosterone. What about testosterone and rheumatoid arthritis? It also calms down the inflammation here. You have lower levels of rheumatoid factor and less number of affected joints, and a lower intake is necessary of anti-inflammatory drugs when oral testosterone is given. It also has autoimmune suppressive action, so you have a high number of CD8 cells that are often suppressor cells, and you decrease the ratio. In this case, you need to decrease the ratio of CD4 to CD8 cells to calm down the autoimmunity. What about testosterone in autoimmune disease? We'll see this later in the section. There's a lot of information that is available, and how to practically utilize this information is important. So we'll see that in the session on it, on the 8th session I presented today. Now, what about women? Well, women also. What happens is women should not take oral estrogen for one reason more. There are a lot of different reasons, but one reason is that it increases inflammation and increases, therefore, the CRP, the big marker of inflammation. And when you give to these women oral estradiol, then becomes safer when you give to them at the same time testosterone. That neutralizes this estrogen-induced rise in CRP. Now, just for your knowledge, it's sufficient. Transdermal estradiol does not increase the CRP. Testosterone and on rheumatism, it also decreases rheumatism. We'll see that in the presentation on it. What about estrogens? Well, transdermal estrogens, no effect. It's a patch or a transdermal gel. It has no effects on CRP, does not increase the inflammation. Vaginal treatment in women decreases the urinary excretion of interleukin-6. So that means that it has an effect of decreasing inflammation in the whole lower part of the body. Urinary inflammatory scores were increased in women with recurrent urinary tract infection, and they had 8 times higher urinary interleukin-6. You had 2.5 times lower urinary interleukin-6 and much lower inflammatory scores when vaginal estrogen was taken. So even vaginal estrogen is good. Of course, you should treat the whole body. So you should take a transdermal and treat the whole body. And if you still have, as a woman, urinary inflammation, you should treat locally. And then you're really on the good, on the improvement. Interesting is that all oral estrogens, not only the non-bioidentical, but also bioidentical oral estrogens, increase the CRP. On a post-conjugate, conjugated equine estrogen, whatever, also the horse estrogens, and melatonin on inflammatory bowel disease. Interesting to see this. Inflammatory bowel disease is especially ulcerative colitis at the end of the colon, is most of the ulcers that appear. It's the large intestines, and the rectum also is involved. And they have a lot of symptoms that slowly develop over time. It's not acute in the beginning. And actually, in their urines, they have 40% lower 6-sulfatoxin melatonin. And the colon mucosa has actually enzymes that can synthesize melatonin. So there must be a problem of lower synthesis. So it's possibly we need to stimulate that part. So when you give melatonin 5 milligrams at bedtime to ulcerative colitis patients, you see actually that the CRP, that is the lower graph, is much lower thanks to the melatonin. It was quite high, and it get higher with time in the ones who didn't receive melatonin, but it kept it lower with melatonin. And also the Mayo Clinic Disease Activity Index is a whole part significantly lower. What about growth hormone and inflammation? Well, growth hormone treatment can also decrease inflammation because there's a study at least that shows that in HIV-infected adults, it decreases the CRP. So we have here had this evidence hormone therapy training program that has all the aspects of information that you need to master all this information, because there's not only a model on immunology and inflammation and infection, there's also a model on reversing aging, on typical basic therapy with the hormones, but much more profound than I personally ever have given. And I think there's not much other people that give lectures on it so profoundly. And there will be also a whole model on fatigue, for example. So really interesting. You'll be able to master also cortisol. Later on, we'll have a longevity model that is also fascinating. So all these courses are included in the 2-year program. They're always, the focus is practice oriented. And it's not so impossible, it's even very easy to make it evidence-based and practical. They're not in conflict. So here we're going to give the synthesis of both. So the interactive, you can, like now, you will be able to ask questions. It's an international project. We have more than partners coming from more than 80 countries, but we have, let's say, more than, I think, 20 different countries helping. There's accreditation with CME credits. You test the knowledge with a multiple choice quiz at the end of every module to get your CME credits. And books, well, many people know my hormone bank, but if you don't know, this is the #1 book to buy if you want to know everything about hormone therapy. It has everything, also what to solve, how to solve problems, what are the best tests, and very didactical, well written. And then this is one of my favorite books, is Testosterone, the Therapy for Real Gentlemen. You have all the references you ever imagined of having on testosterone, even those, for example, on how to treat prostate hypertrophy efficiently, much more than what is given in university courses. Also how to treat with testosterone therapy prostate cancer patients, even active prostate cancer here. What is data that supports it safely, and how to do everything safely. So really everything what you want to know. And these are all big books with a lot of references, but a lot of fundamental information. Reversed Physical Aging is the book that where you learn how to reverse hair loss, all types of hair loss efficiently with hormone therapies and nutritional therapy, also the hair quality, also the face, the aging of the face, also the aging of the senses, the touch, the smell, the hearing, the eyesight. There's a lot of treatments. Don't think everything is impossible, irreversible. Then you're at the wrong lecture if you believe that. You won't get any confirmation here. You will be destabilized if you believe that on this, because, and if you try, you will be convinced that here are a lot of very useful things. And this is one of the books that help. Then you have an atlas of endocrinology for hormone therapy. This is essential for physicians, because if they want to do hormone therapy, a lot of the fine tuning, if it's slightly too much, can be seen on physical examination. So by knowing all this for 20 hormone deficiencies and 19 hormone excesses, really interesting. I did not find signs of excess of thymosin alpha-1, but there was deficiency signs. That's why there's an inequality there. Really interesting, and more than 650 pictures, very useful. And then you have general public books like The Hormone Solution that gives the whole theory that you need with aging, actually to treat all the hormone deficiencies, to feel fine and to look good and to be healthy long. Then this book is also one of my favorites because it's a very personal book on oxytocin. everything. It's the sociability hormone, the hormone that makes you romantic, that makes you loving more, that makes you more friendly with people and like people more. That's the book. It also increases orgasm. That's the book that has everything on it, how to do it and what it does. Patient Hormone Handbook, a reduced form for the patients of the Physician Hormone Handbook. And then we have our partners, and nothing is possible without you, our partners. Just giving a message to them. They are really helpful, and they raise our enthusiasm, and we really like to work with them. So we're going to show some of our partners. Here is Vidya, and Vidya, I'm very grateful for you. Are you going to, do I have to click on them? Okay, I click on it.
Hello, I'm Dr. Vidya Murni from Jakarta, Indonesia. I'm an ex-student of Dr. Thierry and got the certified diploma of advanced.
Tu l'as enlevé, hein? On l'entend pas. Tu l'as enlevé, hein? De la chair, c'est de là que tu dois mettre. Hein? Là, tu dois mettre chair.
Il faut relancer, hein?
Je crois qu'il ne faut pas faire des trucs comme ça.
Hormone therapy on 2011 on Malaysia course. Since then, I have a wide paradigm in treating all the patients coming to see me with the optimum level of hormone and nutritional balance. I saw if I can do the optimum level of hormonal and nutritional balance, and then we can protect them during the pandemic COVID-19. That's why I would like to invite all medical doctors around the world to join postgraduate evidence-based hormone therapy from Dr. Thierry Hertoghe, and let me join his talk on October 6, 2020, and let we become the world-class doctor who can save all the patients from COVID-19 pandemic.
Okay, thank you, Vidya. Thank you a lot. And here we have our next partner, University Compounding Pharmacy.
The history of pharmacy starts off.
We'll have the questions after.
Compounding can be traced back to the dawn of medicine. It can go back far as Egyptian times. At one time in the United States, all medicine was compounded. Everything was a compounded prescription medications. And manufacturing didn't come into play till around 1850. Since then, compounding is still going along and becoming more organized, more technical. And by the end of the 20th century, compounding is in every hospital. It is in retail pharmacies, over 2,000 retail pharmacies, home healthcare pharmacies. So compounding has become a very big specialized division of pharmacy. In 1993, my brother John Grisella and I opened up University Compounding Pharmacy.
There's a big difference between regular mom and pop pharmacies that do a little compounding on the side and professional compounders that do this full time. And one of the biggest differences is the quality control and everything that goes in to making sure that the product that goes out the door is a quality product and it's going to work well for the patient. So we like to say that quality is not just a one-time check. It's not a one-step thing. It's actually built into our product because every step of the way there's quality that's put.
You know, when it comes to customer service, we really take pride in our level of customer satisfaction. And it's one thing to say that we have great customer service, but it's another thing for our customers to really be happy. In order to accomplish this, we have a highly trained staff to answer calls right away as soon as you call in. We understand that your prescriptions are urgent, so you want them processed as soon as possible. And our goal is to make sure that your prescriptions are processed within 24 hours. You can see the high level of compounding that we're offering.
Okay, thank you, University Compounding Pharmacy and Joe Grazella and Dave Metayer, who are making that it helps. Let's see if I go further. Okay, we have a lot of other partners. We'll try to make a customs. They're all selected to be actually people that really like the high standard of medical care. People who really care for the patient. It's not a business. It's a good work in the good sense to create a better world. And all these partners you have here, Nutritional, Forsthaus Apotheek, Laboratoire Copmed, Longevidad. It's an organization that is very active in Brazil, Laboratoire Réuni, Pharma Nord, they're all good. Anti-aging Systems is also international anti-aging, is a very good partner. So we're always very happy of all these partners. We thank you a lot of helping us. And so the next webinar, free webinar, will be on November 17. The educational program will start end of October. And so you can, these are the links. The email below is the email really the easiest to use. This is my Hertoghe Medical School. We have other training programs. office@hertoghe.eu is the email if you want to have questions. And so I thank you for your attention. And do you have any questions? So I need to stop sharing my screen. And in order to see what are the questions, probably here, trying to see chat. Okay. I think it's here. So a question here for Emilian Popa. Is the presentation recorded by any chance? I would love to watch it again as won't be able to attend now. Well, yes, the presentation is recorded and it's available later on, even months later, it will still be available. Where to buy so huge amounts of probiotic powder? I suppose you're talking about the efficient microorganism of the Japanese. They're extremely cheap, extremely cheap. You can buy huge amounts for an extremely cheap. I cannot tell you a price. You need to put on the market, you put on internet, you should search efficient microorganism and see if they are selling it near your place. And that will help you. It's really, really a humanitarian who is on the head of that society. And so he wants everybody to profit from it. TH17 is known to be inflammatory and not anti-inflammatory, contrary to what is said. Okay. Okay, I will check the information about TH17. There's, you're making me a dot, so I will check if the T helper cell 17 is inflammatory and not anti-inflammatory. So I'll see. Thank you for the comment. I always like comments that may help me forward. If I did ever a mistake, I'm sorry for that, but I'll check it. Is it on your Facebook page? Yes, yes, it is on the Facebook page too. A very useful presentation. Thank you a lot. It was very interesting. So I'm going to see if there are other questions. Not seeing any other questions. So let me see, because it may be, yeah. Question also in question and answer. So let me, oh yes, I see here I have a lot of questions then. Okay, hello, Dr. Hertoghe. I'm a big fan of yours and admirer of your work. Have read your hormone handbook. My own stack for boosting immune response during the quarantine was zinc 50 milligrams, calciferol, that's vitamin D3, 5,000 units after breakfast, very good, and acetylcysteine. That is what I didn't propose, but it's certainly good. 1,200 milligrams, glutathione, okay, colostrum, lactobacillus ascorbic acid, 5,000 milligrams, that means 5 grams, that's good, DHA, good. Rotamon, 2 units. I know from Alex that you speak highly of thymosin alpha. Yes, it's the best, yes, for immune system. What are your thoughts regarding my plan? I think your plan is excellent. I would give a little bit more vitamin D, I believe. I would go to 10,000. That's better. And then if ever you come in contact with infection, all the doses you're taking, you should triple them during 5 days. And then I think you're even better than you are now. But you're certainly in very good on the very good track. Here's a question: when you use zinc, do you have to take also copper for balance, or is copper not a concern? Certainly, when you take zinc and you take high amounts of zinc, you might get copper deficient. So basically, for me, it's a little bit easier because as a physician, I check both zinc and copper in blood. And so when I give zinc, it happens, let's say, every 2 or 3 times that I have to add copper, because they are absorbed with the same protein in the intestines, and so there's a sort of competition. So if you give copper in the morning and zinc at night. Where or how do I get multiple probiotics? They seem to die very easily and quickly, or not. Well, multiple probiotics, I just wanted to give you an idea that when you give probiotics, you should give a whole series of samples. More and more, they are for digestive use. Probiotics on the market that have multiple organisms. And so those are generally better. But what I do is I give them to my patient a sample in the morning, sample in the evening of different brands. And this is how I do it. Now, for the efficient microorganism to spread in the environment, that I think the Japanese, I don't remember his name exactly, but the Japanese that did them, those efficient, have during years developed a whole brand of efficient microorganisms that he took the best brands that were helpful together. And so you can type that on internet, and maybe there's a distributor where you are in the United States or in Europe that is selling it, because there are more than 30 countries where it's sold. So you don't need to order it from Japan. Where do you buy probiotic powder to spray? Well, I just answered the same question. Just type efficient microorganism and find a distributor in your neighborhood that distributes it. Which is the best time to take the zinc-related supplement, like zinc biglycinate? Take it before bedtime. There's an interaction. It's better absorbed at night, and there's an interaction with melatonin. So at night you have more melatonin. You will absorb more zinc if you take it at bedtime. Some patients do not absorb well, and they have to take relatively high amounts of zinc. So they take in the morning and in the evening, but generally it is in the evening. Recently, NPR Radio Network criticized practitioners prescribing Tamsin alpha therapies. How would you respond to such media credit? The media often is not well informed. So I would, I believe that we are here for a spiritual reason. I believe that you have a job to do in this life. I believe that you're the best to do that job. So I believe that you have to give information. But when you encounter people who don't believe you, or don't want to, or you write things that are opposite to what you said, be the small professor, the friendly small professor. Same thing, if you go on a medical board, you always be the small professor. That means the very nice person, but who always explains, doesn't want to convince the other, just wants to give the information. And by his friendliness, he will convince more people. But and just be patient. It's not your problem if the other doesn't want to be convinced. You don't need to convince other people. You're a good person and you just do your good job. And I think that's enough. And what I do is I get all the scientific references together, and that's my way of being able to respond to criticism. I say, look, these are my references. What are yours? Then here from Emilian Popa, is the presentation quote by Incha? Okay, I answered that already. Dr. Cherry, this is Dr. Grace Haya. Can we increase growth hormone only by doing intermittent fasting rather than injecting growth hormone? In intermittent fasting, I haven't checked the information if it increases growth hormone. Normally, what happens in intermittent fasting is that you have a period where the sugar goes down because you're fasting. And when the sugar goes down, hyperglycemic hormones like growth hormone and cortisol are more secreted. So you should probably make more growth hormone. For example, at certain moment, I was fasting a lot and my IGF-1 went up. The IGF-1 is a marker of growth hormone activity. It went up in a very important month because I didn't have any digestive troubles, because I ate less, because I also took amino acids when eating less, just to concentrate on good amino acids, and that improved. So I think you could do intermittent fasting, good way, but also if the fasting is longer than just 16 hours, you might take, when you consume foods, amino acids, and that will boost the growth hormone. But it's not enough to correct a growth hormone deficiency that you have at age 40 or age 50. If you're at age 30, it probably is enough. 35 is in between. 40, you certainly need to be treated with or without intermittent fasting. And then Sophie de Hainaut, what do you think about the endocannabinoid system completely linked to the immune system and boosting its deficiency with CBD? I don't know enough about, I know it's very good things about those endocannabinoids, but I don't know enough information to be able to inform. Do you recommend coconut oil? If so, how much do you recommend a day? I certainly recommend coconut oil, but not for cooking, because there's 2 or 4% polyunsaturated fats, and by cooking, they will burn. I recommend to eat saturated fat because we need it. It's good for the immune system. And coconut oil has anti-yeast effects, antibacterial effects, and antiviral effects. So I certainly recommend. Difficult to give you an idea how much to take. Maybe you should take a soup spoon a day or half a spoon. But you can also have saturated fats. Other way, I take a lot of coconut. I take coconut yogurt. I take sometimes a real coconut and eat the inside when it's some species of coconut permit that. So I'm well in the coconut oil. You are an outspoken supporter of 24-hour urine test. Yes, this concern shows that patients with symptoms of thyroid deficiency, and despite good levels of TSH, T4, and T3, have very low levels of free T4 and free T3 in 24-hour urine. Yes. Which pathology causes this, and does it help to prescribe to these patients thyroid medication? Most people who have low thyroid hormones in the urines are hypothyroid. I must admit one thing is that I do 24-hour urines and I do blood tests, but I never do them without a good physical examination and a clinical assessment. And I always find in my testing, either in urines or in the blood, a reason to treat them when they have a lot of symptoms, so an additional reason. But I believe that between 40 and 70% of the people are hypothyroid and need to have treatment, even after age 30 or 25. And the thing is that it looks so difficult to believe for many people that they have a deficiency, while when they come on our consultation, they have maybe 5 or 8 hormone deficiency or even more. But that's reality. Nobody is born with optimal levels of all 35 important hormones. And when you're age 30, you already have at least 5 or 6 deficiencies that are starting to make you suffer. And so I believe that the testing is just to help you support your diagnosis that you already started to your hormone diagnosis. They already started at clinical examination and things. And so it's now the 24-hour urine has one advantage on blood, is that it's a 24-hour picture of your hormones, while the blood test fluctuates all the time, and thyroid hormones can fluctuate from 100 to 200% more during the day. The TSH fluctuates also like double, triples at night, for example. You never know with a blood test that is snapshot if it corresponds to the average level during 24 hours. Okay. Giving high dose intramuscular vitamin D, would you not need calcium as well? If so, how much, and is an oral form? That's a very intelligent question. Of course, if the person is not taking enough calcium, giving vitamin D is even won't help. So you need to have calcium to support the bones, especially if there's osteoporosis. Here, vitamin D that what I was talking about was mainly focused not on the bones, but mainly focused on improving your immune system. And then it's different. But if the person has osteoporosis, smaller bones or weaker bones, if you do an osteodensitometry, you can check the bone density and know if it's also necessary for the bones, then you certainly have to give calcium. So I would also look at the calcium levels in blood. Many people say they're not important, but did you know that a study showed that the calcium is low when vitamin D is low? And that is proportional. So if you increase the vitamin D level, increase it, the calcium increases. So I do check if the calcium is not average, but it's low normal, then I add calcium and vitamin D. But did you know also that calcium is on all foods? So if a person eats a lot, there's no problem. If the person eats little, then there's calcium supplementation necessary, certainly with vitamin D. Good observation. If you have a patient with normal TSH and low free T3, will you give thyroid treatment? If that patient with low free T3 has signs at physical examination of thyroid deficiency, like puffy lower eyelids, puffy face, tendency to weight gain, dry skin, slow Achilles reflexes, and has also complaints of thyroid deficiency, I would certainly treat this person who's low normal. You have to know that many scientific tests, in scientific research, they never talk about reference range, actually. They talk about a value in the lower third of the reference range. And so basically, many studies have shown that there's pathology if you're in the lower third or lower fourth or lower fifth of the reference range. So you better be treated if you have low free T3. It's often linked with more mortality. What do you need with patients who need melatonin? What do you do with patients who need melatonin, but get nightmares even with 1 milligram dose? Almost everybody in the world will get vivid dreams and nightmares with 1 milligram per day. That is normally an excess dose. Especially if it's taken sublingually. Sublingually, the normal dose is 0.1 to 0.2 milligrams, not more, except when there's jet lag. With 1 milligram dose, you will sleep very deeply, 3 or 4 hours. And then after 3 or 4 hours, you will start sweating, being in a sort of nightmare. Everything will be intense and have 2 or 3 hours difficulties of sleeping. That is a sign of an overdose. So I think you're an overdose. You have nightmares with it. You have to take less, and sublingual will work better. Is CME available when utilizing recorded lectures? Yes, it's an e-learning. But the thing is that we're going to have our CME accreditation later because so it's better that this, if you really want to have the CME credits also for the beginning, that you might wait because we'll get them in the weeks after, because we had to change the system. We had an accreditation for lectures like this, but not afterwards. So if we're in e-learning for recorded lectures, we need another, we need to wait, but it will be. Can hormones help with rectocell or something else can help? What is rectocell? Rectocell is a part of the rectum that gets out of the body. The rectum, that's the end of the digestive tract, because the wall is not strong. I'm not sure that rectocell can be completely improved with therapy. If you want to try, you have to put locally testosterone in a dose that is adapted. If you're a woman, for example, it's a lower dose than for a man. And you need to put a certain device on it in certain moments so that you retrain the muscle. I think there's always a solution that doesn't need surgery, but you need to do a special, to think outside of the box and to put a special device and do exercise. And with male hormones, you're going to make everything firmer. For example, if a woman has urinary incontinence, so easy to improve. You just put a little testosterone locally, very small dose, and make her make contractions, 10 contractions. Each time she puts once or twice a day. And after 3 to 6 weeks, or maybe 12 weeks, it's over. And then maybe every year she has to do a little cure, but basically it helps. So put locally male hormone. GM, is this webinar will be available for others? Yes, where we can find a record of this webinar. Thanks in advance. Well, normally, I think it will be on the Hertoghe Medical School website. So hertoghemedicalschool.eu website, you'll be able to have the recording. I don't know when, maybe tomorrow or in several days. I have a team who does it, but I don't really know. How can we buy Thymosin alpha-1? I don't know which country as this, Diana and Niti, but you can buy Thymosin alpha-1 in 30 countries in the pharmacy. In Europe, it's only in Italy. And you have to look maybe on Italy where it's registered. And that's the best way. There are patients who are trying to do it through internet. And so it's also in some peptide websites available, but it doesn't seem to work as well. And there was in the United States a very good pharmacy that sold it and even made it, but they had some problem with the FDA. So the FDA is really in the United States not always the best friend of the patient. They don't always do the good working that we would expect from them to do. What kind of bacteria are in the solutions? I'm not sure about all the kind. I haven't really investigated. There's so much knowledge, and I have centered a bit on hormone therapy and nutritional therapies, but not on those probiotics. But I think there's Saccharomycetes. There's a little friendly yeast in it, and there's, I think, Lactobacillus acidophilus, but there are other strands that are, it's actually made for plants, actually. And then they have deviated to other uses. What do you think about hydroxychloro? I don't know about hydroxychloro. How often to take vitamin D, 300,000 international units? Here they were taking it every 3 months. But it could be every month and a half. Okay, they're saying that I have almost to stop, so I'll continue some questions and then we'll stop. What is an affordable option for purchasing Thymosin alpha-1? Some pharmacies charge $400 per month. Wow. Because, well, yes, it's a bit that dose if you go on the higher range. Otherwise, it's 250 euros, which is $300. Comment avoir l'hormone de croissance en France? How to get growth hormone in France? Well, in France, it's a difficulty. You have to go to Belgium. Some pharmacies in France do deliver it, but not always easy. Not in Paris, outside of Paris. Is it possible to use testosterone for hypogonadic, hypergonadotropic 42-year-old man to improve fertility? Yes, you can use testosterone with smaller doses, and then you can increase your testosterone by giving HCG, which is human chorionic gonadotropin, or Pregnil in pharmacies here, because it stimulates your testosterone production, but also stimulates a bit your female hormones. You have to be a little careful. It should be done under guidance of a competent doctor. But testosterone that you can take is transdermal, maximum, I would say 60 milligrams, or otherwise it can suppress a bit your spermatogenesis. How to give intravenous vitamin C to patients with very high ferritin in COVID case? Will it be harmful? Vitamin C will certainly not be harmful, even if you have a high ferritin, because it might help to detoxify. So I don't think it will be. You do have to take, I think, extra other antioxidants like coenzyme Q10 and vitamin E, because the high ferritin has a lot of oxidative stress with it. But also try to lower the high ferritin. There are methods to do it. Find a doctor for it. Thank you for this informative talk. Can a woman in the perimenopause on HRT in case of a very high SHBG take more than 4 pumps of estradiol if there's no symptom resolution? A woman can take, a woman has a very high SHBG because she's lacking androgens in most cases, or just not drinking enough water. But you can take more than 4 pumps of estradiol if you still have the symptoms. Now, if you still have the symptoms, it might be that you don't apply the transdermal estradiol well. You have to transport it on the inner and outer arm and the shoulder, so that and go 10 times over. On the larger the surface, the more constant the effect will be. And I think you're putting on a too small surface, like here. And then the last question is then from François de Sadelaire: is oral administration of vitamin C effective? Yes, it is. Absorption is correct, and maybe less kidney elimination if not in one time administered. I think you can administer several times a day vitamin C, and you will have a certain efficacy. That's the method. If you have COVID-19, in the beginning, you're not going to do an intravenous. You're generally going to get directly oral, and you're going to increase the dose, like taking 1 gram every 2 hours, for example. Okay, so how to take vitamin A prophylactic without toxicity risk? This is the last question. Vitamin A is safe when it's retinol palmitate, and I take 100,000 international units, even 120,000 a day. It's okay. But if you take vitamin A acetate, that's dangerous. If you take Roacutan or things, they are bad for the liver. So you have to take a better form, which is really the liposoluble vitamin A, retinol palmitate. That's very safe. Okay, I thank you for attending. You've been a great public. I see there are a lot of other questions. There was a good attendance also. Thank you, and we'll see you the next time in November. Bye-bye. And maybe in October also with our educational program. See you. Bye-bye.